Hello.
Hi, I'm Dr. Anne, one of the doctors here in the GP. I'm speaking with Mrs. Elizabeth Dawkins.
Yeah,
Yeah, so could you confirm your age for me?
I'm 60.
Okay, and how can I call you?
You can call me Elizabeth.
Okay, Elizabeth. So, what brings you here to the GP today?
Well, doctor, I've been having some really trouble like going to sleep. I'm really troubled by that. Please help me.
Okay, sure, Elizabeth. I'll definitely help you with that. So, you said that you're having trouble sleeping. Could you elaborate a bit more on that?
Yeah, doctor, this sleep. I've been having this issue for the last 3 months, and whenever I go to bed, I'm unable to sleep, and I'm really troubled by it.
Okay, I'm so sorry to hear that. We'll definitely help you with that. So you've been saying since it's 3 months. So have you done anything about this since the 3 months?
Yeah, I searched it online and there were some tips. I started reading, listening to like white music and also like mixed brandy with a warm milk of cup at the night time. But it didn't help me that much and I'm really, struggling right now.
Yeah, I can see how it would be troubling, but I like to appreciate you for taking all the precautions that were necessary and doing your own research. So I want to ask a few questions to make sure I can give you a proper, way to deal with this problem. Okay?
Okay, thank you, doctor.
Yeah. So, would you say when do you go to sleep? I mean, to the bed at night, would you say?
Around about 10:30 p.m.
Okay. And when do you fall asleep?
Almost like 3 a.m.
Okay. And do you wake up in the middle of the night after falling asleep?
No, no, like once I'm asleep, that's okay. I've just had troubling like falling to sleep.
Okay, good. Could you just walk me through your, bedtime routine if that's possible?
Like what, doctor?
Like, what do you do just before going to sleep?
I read.
Okay. That's good. And do you watch any screens before going to sleep?
No, no, doctor, no, doctor.
Okay, that's good. And do you drink any sort of coffee or caffeinated drinks before going to sleep?
No, I don't like that, doctor.
Okay, that's good. And Elizabeth, so you said it's been since 3 months you're having this problem. How are you coping with it?
I'm not coping it really good, doctor. Uh, I feel sleep during the afternoon, like I need to take an afternoon nap. I feel like that I'm unable to concentrate really well. So this sleeping issue has been troubling me.
Okay. On a scale of 1 to 10, 1 being the lowest and 10 being the highest, could you rate your mood for me?
Almost 6.
Okay. So, just a couple more questions. Would you say have you lost any sort of, pleasure doing the things that you used to enjoy before?
Yeah, doctor, now you have mentioned it, I really liked to cooking before, but now I don't feel it that much. So I think that I have lost such interest. Yeah, doctor.
Okay. Have you been feeling hopeless lately?
No, no, not like that.
Okay. So, could you think of anything that happened before the 3 months of significant in your life has happened?
Yes, doctor, my husband passed away 6 months ago, and we were devastated by that. So, but it has been some time, and I have been coping it well. But the sleeping issue, yeah, I don't know what's really happening to me.
Okay, I'm so sorry to hear about your husband, Elizabeth. Is there anyone, right now who you're living with?
I live alone, doctor.
Okay. Do you have any friends or family over who can check on you all the time?
Yeah, yeah, I have two daughters, and they live nearby. They usually come and visit me. Okay, but lately, I like to live alone.
Okay, okay. So I can see from your notes that you have been diagnosed with rheumatoid arthritis. And how are you coping with that?
It's going good. I've been taking medications regularly, and it's good.
Any sort of pain lately?
No, no.
Okay. Everything okay with your general health?
Yeah,
Yeah. Have you had any fever recently?
No.
Any weight loss?
Nope.
Yeah, okay. And thank you for all that. I would like to do a small examination on you. I'd like to record your blood pressure, oxygen saturation levels, your heart rate, and have an overall look over your body, looking at your eyes. And is that if that's okay with you?
Sure, doctor.
Yeah, thank you. The examination findings are okay. Thank you so much for all of that, Elizabeth. Well, after having a look at you and after having a chat with you, uh, I feel like you might, be feeling a bit low lately, if I'm not wrong. Is that what's happening?
2 minutes remaining.
Yeah, maybe doctor, but I don't know what's really happening to me.
Yeah. So you said you're having trouble sleeping, and I suspect it might be something called as insomnia. Do you have any idea what that is?
No, doctor, what is that?
So it's a condition where a person, tries hard to fall asleep, but that's not what happening. Usually, when people go to sleep, go to bed, they fall asleep within 30 minutes. But however, that's not happening with you. Yeah.
Yeah.
Yeah. So there are a couple of things that we could do and you could do as well to tackle this problem. I'll be giving you a leaflet and some links so that you can read up more on that so that you don't need to remember everything at one go. So basically, what we can do right now is I'll be referring you to a psychologist where you can talk about what's happening with you and how you're feeling. And this is because I feel like you're feeling a bit low since your husband has passed away. Correct me if I'm wrong.
Yeah, maybe it can be the reason, yeah, doctor.
Yeah. And also the medication that you're taking, the methotrexate for your rheumatoid arthritis, it might also, elevate the low mood that you're feeling. Like, you feel a bit more low than usual, yeah?
Okay.
However, stopping the medication is not the right move right now in your case. So I'll be informing my seniors about it and I'll see what they are going to say about it. Is that okay?
But doctor, wouldn't you like prescribe me some sleeping medicines so that I feel, a bit better?
Yeah, coming to that, Elizabeth, right now I'd like to, suggest you go to the talking therapy first, and I'll also give you a leaflet on how to sleep better so that you can do those things in the first place. And if that doesn't work out, definitely you can go for the other option of going to medications. If that's okay, yeah?
Okay, doctor.
Move on to the next station.
Well, that was really great. Seems like you're all ready to go to the PLAB examination. Uh,
I think it is a lot of irrelevant history. That's what happened in holidays.
yeah, yeah, like you spent a lot of time in data gathering.
Yeah,
Okay,
yeah.
and but it was good. You like asked all of the questions, like you made me answer all the questions. That was really good. Okay, you collected all the history. There was something that I would like to point out. You didn't ask about my diet, exercise, smoking, alcohol history. Okay, that was really
Yeah.
important. Okay, no
Mhm.
doubt I didn't have any issue with that. Okay, but still you need to ask the patient about if they have some sleeping issues. Okay, and always ask about the ice component. What are their ideas or what are their
Mm.
concerns? Okay, or what do they expect out of this consultation? Okay, that was really important. And in management, it was good. You told me that it's insomnia and mostly because of depression, maybe my husband passed away. You asked me to go to the psychologist for therapy, and you mentioned about the pamphlet, leaflets. Uh, I'll, it's my opinion that you also need to tell about it yourself, like what is sleep hygiene,
Yeah, yeah.
okay? Like mention 2 to 3 points about sleep hygiene, like go to bed
Mm.
only at the time when you feel sleepy, okay? And exercise, do not take afternoon naps, make a sleep regime of going to early to bed, early to rise, such things, okay? And then you can tell the patient that first do these steps, then we'll see that if it doesn't help, then we'll give some medication.
Yeah.
Okay, like go in a systemic way. Okay, other than that, it was perfect. Okay, and it seems like you're ready. Yeah, just don't lose confidence. It was good.
Thank you so much.
Now I'm handing you over to the examiners.
Hi, Dr. Tanmay. And thank you, Dr. Umar. That was very comprehensive. And you brought out a lot of good, important points, like definitely asking the ICE history because this patient actually comes with insomnia, and what you know about this patient is about the rheumatoid arthritis. So, getting an idea about, what makes them feel this way is very important for you so that you can frame it to them on how this, is affecting them and what this could be, right? So you definitely need to understand what's going on in their mind before you actually break or give them a clear understanding of what you understood from the situation. And some important points that I wanted to point out was you did mention one of the concerns or one of the expectations was I want sleeping pills. But you mentioned that we'll try out this and then we'll try giving you sleeping pills if it doesn't work. Instead, you need to give an idea about why you wouldn't want to give sleeping pills first, right? Because they may have some side effects, and we want to try something more safer first, which can definitely work in your case, right? By actually mentioning it like that, it would be a more preferred option to try the other non-medical managements because these are one of their expectations, and you need to answer it or address it properly.
And besides, this is a patient where she's a 60-year-old lady who's lost her husband and having trouble sleeping. So giving pills shouldn't be that much of an issue. She will get the pills. Like you might not be able to give it, but somebody will give it. So you can assure her. So I'll definitely make sure I'll talk to someone. I'll talk to the senior, and we'll give you the pills. We'll just see the other things first. But so don't completely
negate the idea
negate
of
that.
not.
Yeah, because that's her main expectation. So
Yeah,
always
so
try to keep that low threshold for that. Yeah.
mainly because this is a depression station. So insomnia is one of the symptoms. So you need to explain it such that this is a depression station which is affecting her life. So when depression is affecting your life, it's moderate depression, and the treatment for moderate depression does include medications. So you have to offer medications for moderate depression, right? And since it's a depression station, there are a couple of things that you have to do for safety netting. Right. So if there's a person who is depressed and you have identified, and because you kept saying low mood, yeah, this is because of low mood, because that is your diagnosis if you think about it. Insomnia is just one of your symptoms because that's the presenting symptom that she comes with, right? So you need to bring that correlation that this sleeplessness is mainly because of your low mood, and I suspect that you might be suffering from depression, and the severity is somewhere around moderate. That will be like the full explanation of the diagnosis, right? And while doing that, you need to also explain them, since it's a depression station, you have to do a lot of safety netting. So if this person who is depressed and you haven't given her management and you're like, just try sleeping, then she might actually, she might go into a whole phase where she can't do it, even the doctor is just telling her to sleep. Then it might affect her very badly, and she might actually try to commit suicide. So those are the extreme risks of depression which you need to keep in mind. So always safeguard for suicidal history. That is of utmost importance once a depression station comes to you, right? So you need to do safety netting for that. Have you ever had, because some of your questions were very direct, like do you feel hopeless, like maybe signpost those. Sometimes in these situations people usually tend to feel those kind of ways where you're actually talking to them, because your response should be tailored to how they are in the situation at that moment, right? Yeah, the examiner will take over.
Right. Thank you, Dr. Umar, for being the stimulator. So, Yeah, everything they said, it's really good. And like if you notice, you've covered almost everything that needs to be covered. Like everything is there. But one thing I noticed is that you're trying to rush. Even I mean, at least in after the 2 minute bell, the rush starts. That's okay. But it feels like you're rushing from the beginning. So try to keep in mind that you don't have to cover everything. Like that's not expected out of you at all. So always just try to see where the patient is trying to take you. So in this situation, in the beginning when you asked an open-ended question itself, he's given you a lot of information, right, about the sleep issue. So there was no point going into asking more detail about the sleep history itself, like when do you, how long does it take for you to fall asleep. All that is they've already given you in the first long open-ended question itself. So one important, so always I tell in data gathering, there's a structure you need to maintain, which is not the structure that you have to ask all the questions. The structure is always keep in mind you need to start with the presenting complaint, then elaborate presenting complaint, which is just one question, which is just tell me more. That's all. And after that, if anything that they didn't tell, so when they're telling you, keep the Socrates or Odipara in your mind. So that is something that you have to ask. So immediately after the open question, you have to ask the closed questions. So the closed questions include the questions that they haven't already told you, right? The answers that they haven't already told you. That's those are the ones you need to ask, which shouldn't be more than two or three questions, because there are more important questions that are coming, which is even if you don't ask this Socrates Odipara after asking tell me more, that's okay, because going to at this by this point you have an idea in your mind, right? So in the beginning, after he told you the entire thing, that I've been having trouble sleeping for the last 3 months, you kind of have had an idea what this could be. What did you think at that point what the diagnosis was?
Insomnia.
Yeah, and what did you think the cause was?
Something might have happened and it triggered the insomnia because it was fine before, is what I felt.
So
Only three
insomnia is
months
a
is too.
symptom, all right? It's not a
Yeah,
diagnosis.
yeah,
So keep that
yeah.
in mind. Insomnia is just a symptom. So always, so whenever you feel that you only got a symptom, think about next immediate thing is etiology. So think about what could be
Yeah.
causing it. So don't need to explore more into the thing itself. So then keep so at this point you have a symptom called insomnia. Now when you have a symptom or when you have a set of symptoms, the next question, so structure so far is presenting complaint, elaborate, which is one opening question, and then either Socrates or Odipara, which is only two or three questions within out of that. And then next is differential diagnosis, that is basically three C's. That's what we always tell, which is common, critical, and cancer. So if you manage to ask three C's, then your entire differentials, because you're not trying to diagnose, this is not a real patient. You're not trying to, uh, you're not even having to give any treatment. You're only talking to the examiner. If you think about it, you're only showing the examiner what you're trying to do. All right. So always try to reserve your questions. You don't have to ask everything. So main thing is that you need to know that you need to get to management fast. You only got to management at 2 minutes.
Yeah.
Yeah, right. Because that happens. That's something that happens a lot. That happened to us even before the exam. Also, we were still struggling, and so this timer is something that actually we came up with after. We were thinking, how do we train ourselves? How do we train our internal clock to tell us when the 4 minutes is finished? Because it's very difficult, right? Because so one way that we were and experimenting was to count the questions that we have asked so far, which is like each question takes 1 or 2 seconds. So how many questions have I asked so far, which is way too difficult. So so best way is to just keep the timer in front of you and practice. So just keep practicing and keep looking at the timer. So that way, if you'll know at some point, you'll think that okay, maybe it's been 2 minutes now. I've asked till elaboration or presenting complaint only, and then if you look at the timer, it's probably already 4 minutes. That means you need to you'll calibrate your internal clock like that. That only comes with just looking at the timer and practicing. All right. So yeah, so now we're coming back to the differential diagnosis now. So the three C's. So that is common. So what is the most common etiology for the presenting complaint, a symptom or a set of symptoms? So insomnia, most common is, what do you think is the most
Like,
common?
I
You
don't know,
don't have to
like,
be true. You don't have to be accurate.
more screen time before, like,
So
no proper sleep hygiene.
yeah, so that is
That's the
sleep
first thing.
hygiene. So that's the most
Yeah.
common thing. So that you can ask. So how is so that also is already mentioned. So he said that yeah, I try to go to sleep early and all that. Then you so next question that you can ask for that is do you take caffeine, or do you take coffee or alcohol before sleeping? And he's also mentioned that he takes brandy with milk and all that. So you don't have to ask specifically about alcohol history again. So now, so common, just one question. I'll try to always ask just one question that just shows the examiner that okay, she's covered the most common presentation. Then go to the critical. So critical would be always think about what is the worst thing that can happen to this patient. So this is something that will help you in your data gathering and in your management. Okay, so that is, anytime you see a patient, always think about what is the worst thing that can happen to him or her. So now, insomnia is something. It's a basically psychiatric case. So any psychiatric case, what is the worst thing that can happen is suicide, right? So always ask that. So that is basically your segue into depression questions. Then, so once you ask them about mood, and immediately go to anhedonia. So these are the two questions that you ask really well, and then you ask, are you feeling hopeless? Which I'm not sure why that felt a little scripted for me, but try to signpost these questions when you're asking these things. So instead of asking like that, because hopeless is a very generic term, it's not um, how do you define hopelessness? So you
Yes.
can't tell that. So always try to ask things that you can define what you exactly mean by that. So they don't have to ask you a question and waste more time, like what do you mean. They'll definitely say that if you ask something like that. So always say that okay, since you mentioned your mood is low, when people feel like this, they might feel like hurting themselves or causing harm to themselves. Is that something that you feel anytime? So always be very clear in your questions. So that is your critical. So critical is done, and then cancer. So in this, so what could be the how can you ask a cancer question in insomnia?
The flaws, I guess, the few
Perfect.
fate laws.
Awesome. That's what. So
Yeah.
even cancer can cause insomnia, right? Just rule that out. Just ask, have you been? It's a long history. So just ask have you been having any weight loss? That's all done. Now your differentials is done. So by this point, you already have a diagnosis, which is depression, right? Because your low mood and
Yes.
anhedonia both. So that right? Low mood and anhedonia, if both of them are true, you already got your diagnosis for depression. You don't have to ask much. Okay.
Yeah.
Only thing is suicide risk. That's all. So now, by this time, you have your diagnosis. You've ruled out the major red flags. Now, your data gathering is almost complete, right? This technically shouldn't take you more than 3 minutes if you practice enough. I mean, it's not that easy, I know, but the simulators there are very well trained, and they also have a time script that they follow. So they know how
Yeah.
what time that, so they'll realize okay, if it's been 4 minutes, they know that they need to somehow ask a few more questions that they need to ask. They have a script, so they will try to nudge you, but don't take that for granted. So always keep a structure in your mind so that you know when you need to skip. Now, you're different. You have a diagnosis. Now, what are the other things in data gathering that you have to definitely ask in every station?
Mm, Ice, yeah, ice. Idea
Perfect.
consonant. Yeah.
Ice, and before that, before ice and after differentials.
Anything else that is bothering you?
No, no, no. Past medical history. PMAFTERSA.
No, yeah.
PMAFTERSA
Past
is
medical
also very, very
history.
important because that
Basic,
is
yeah.
something a lot of people waste a lot of time in because they'll end up asking everything. All PMAFTERSA they'll ask. That's something that's very, very important. So, because there also don't try to break your head about what are the things I need to ask, what are the things I can skip. Don't worry, nobody cares. Even the examiner needs to know that you are asking the past history, you're asking social history. That's enough. They just need to see that okay, this person knows that this needs to be asked. That's all. It's not. He's not just. The doctor is not just treating the current presenting complaint. They're looking at the patient as a whole. So that is basically by PMAFTOSA. So always just quickly ask if you have any other medical conditions, or like you did. I can see from my notes that you have. How are you managing that? And what medications are you taking? How is your pain? All that you ask. That's really good. Now ask about previous mental illnesses. This is a psychiatric case. Every time you see any type of, always you have to ask, have you ever had anything similar in the past? That's very important. Other than any
Yeah.
other illnesses, this in the past is more important also, right? So any previous psychiatric illnesses, then medications is already covered. Now social history. So anytime you see young patient or an elderly patient, you cannot miss social history. Okay, where does she stay? Who does she live with? How is she living? That's very, very important. And the more elderly they are, you have to ask even more questions. Like how do they carry out their daily activities? And is there anyone that come to check on them? All these things are very important because once they leave your consultation room, where are they going? Are they living alone? You need to be very careful about that. So social history, it's also just two questions. So where do you stay? Who lives with you? Who stays with you? And is everything all right at home? That's enough. It's very vague question. If they have an answer, they'll definitely tell you in that, saying, "No, it's my, I've been having issues with financially or anything like that." They'll definitely bring it up. You don't have to ask everything specifically. So is everything okay at home? That's enough. Then now your data gathering is almost complete. Now all you have is ice. Just quickly ask. Make sure you ask all three. You just ask ideas, but expectations is something. If you had asked, you would have known that they're looking for medication for sleeping pills. That came very late because he himself had to mention to you that he wants the pills. So always, whenever you start ice, you have to finish it because it doesn't take long. It's just three questions. It just takes you maybe like 3 seconds to ask one question. Always finish the entire ice, and then only your data gathering is done. All right. So now we're going on to. Oh, sorry. Your data gathering is still not complete. You have examination. So a lot of people
Yeah.
think examination is a part of management. It's not. It's data gathering only. So
Okay.
examination. So don't waste too much time on that as well because if you know realize that you've already taken a long data gathering, if you still waste time in mentioning I would like to do these examination, I would like to do these tests, that's wasting your time still on data gathering. So remember that because your examination is part of your data gathering. So just quickly mention vitals and general physical examination is very important, and whatever the problem they have come with. So in this insomnia, there's nothing, but she has rheumatoid arthritis. So just say that I'd like to do some general physical examination, including your joint examination. That and blood test you don't even have to mention at this point because there's nothing that you need to immediately. So in the data gathering, so for blood tests also we have two different blood tests that you'll have to verbalize. The one is the blood test that you would immediately do, right? In the GP or whatever setting there is, in the primary care or in the emergency setting, whatever you can do, that will give you the diagnosis immediately, which is not CBC, LFT, RFT. These are not the tests that you need to mention at that point. So this is the stage where you can mention like things like ECG, urine dipstick, pregnancy test. These are the things that you can mention at this stage. So here in this state, in this case, you actually don't have any tests that you need to mention. Maybe joint X-ray, but she doesn't have any pain, so it's fine. So just say I'll do like general physical examination, joint examination, done. Now move on to management. So management, you just mentioned that that came out very abruptly, the way you mentioned the management, right? Sorry, the diagnosis. So you said, I
Yeah.
believe you have some, because I realized, because that's when the 2 minute bell rang and you had to rush. But be very careful when you say these things, that throws them off, because it will waste your time in management if the diagnosis throws them off, because you'll have to spend more time explaining that. So always say that. So here, so again, insomnia is not a diagnosis. Okay.
Yeah.
So always you have to tell the diagnosis with, if it is a symptom that you have to give as a diagnosis, always give the etiology. So say that this is you're having insomnia, it is trouble sleeping, but I feel this is because of depression. So always give the actual etiology, and here the etiology is the actual diagnosis. So say that,
Okay.
and say that I can totally understand, why you would want medications. I can understand, but you do actually understand, right, why she's asking for medication, because she's already told you that she's tried everything. She's been trying to drink alcohol. Usually alcohol helps, like, if it's not an organic psychiatric problem, usually a lot of people,
Okay.
it helps. So if all that is not helping, then only she's come to you. Means you have to show them that you can't just say that I just go try to sleep again. Don't try to give the same things that they've tried already. So that's very important, because you might think that you're just following protocol, but that's something that hurts the patient a lot, right? Because they have no choice. They've got this appointment after a lot of difficulty, and they might not get another, right? So you have to be very empathetic about that. So yeah, so management, now give the diagnosis, tell what it is. And you mentioned too much about, most people take 30 minutes to fall asleep. That's not needed. I mean, that's all common knowledge, right? Like, people have been sleeping from their childhood. Everyone knows how it works. So don't waste time explaining these things. But explain the fact that why it's causing her. So say that when people undergo traumatic events in life, that can affect the mood, which can in turn affect your sleep, right? So that way you're actually giving her more value in explaining the diagnosis. So now, after that, so like you said, you try to summarize, right? Like you try to say, there are things that I can do, there's things that you can do, there are things that we can do. That's very uh, like, it seems very scripted. So always try to expand it. So there are things that we can do, like, there are things, and there are things that you can do, like. So say a couple of things, and then go into which would you like to hear about first. Then you giving her an option, right? Otherwise there's no point listing all the things if you're not going to again go through everything, right? So if you're listing things, give them an option. Okay, which one would you like to hear about? All right. So that way you also know what they want to hear about, because when you ask that question, she'll definitely tell you, no, I'd like to get some medications, right? And you can say that, okay, yes, that's something that we can definitely do, because always, reassure. There's a very fine line between reassurance and overpromising, right? And the very few cases where you can overpromise, because there are cases where, so what that means is, so ethically, I mean, sorry, morally feeling like, you see a patient who's struggling, asking for a unreasonable request. That is, there is something that, even if you know that it's against protocol, it's something that you can overpromise, but with the safety netting of the senior. so that you're
Yeah.
not making any mistake in the exam, right? But you're still a human. You're showing the emotion. You can't be. You don't have to be very apathetic, like saying no, that's not possible. We can't do that. So you should never have to. You should never be very 100%. Always say that yes, I'll definitely do my best. I'll talk to the senior and I'll see what we can do. But I'd like to tell you what other things that we can do also, which is there's something called sleep hygiene, which is something that you've already been trying, but I'd like to help you more to see if it improves, and I'll give you more reading material. So that is something that you did. That's really good. So whenever you know that there's a lot to say, just say that I'll give you reading material about it. Then
Mm.
so now that is done. Sleep is so that's her main symptom that is done. But now whenever you have the 2 minutes, we always say there are three things that you have to always remember. Do you know
Okay.
what those three things are? Whenever you hear the 2 minute bell. Okay, so this is for management basically. So that is safety netting, leaflets and pamphlets, and follow up. All right. If you cover these three things, your management is almost covered. Even if you have if you have 1 minute, you're actually covering a lot of important aspects of management by just doing these three things. Right. So that is safety netting is basically, like I said in the beginning, what is the worst thing that can happen to this patient? So safety net for that. So it's a psychiatric patient. So safety net for suicidal risk. So don't even think about suicidal risk. Just say if you feel like you can't cope with this, I'll give you a number that you can call at any time that they'll be able to talk to you, which is the 24-hour Good Samaritan line, right? So so there are so you don't have to specifically mention these resources. All you have to do is that you need to show the examiner that you know these, that you know that NHS has resources to help them, and you are telling them that. That's enough. So say that we and that is safety netting, and leaflets and pamphlets is something that you did. That's really good, and it's I just want to reiterate because leaflets and pamphlets is something the GMC and the NHS spends like millions of pounds every year printing out these physical pamphlets for every single thing. They want the patients to be well informed, right? Because there's a lot of misinformation out there, and if they have a pamphlet with the NHS logo on it, they know that they can trust it, right? So that is something that they want you to give it to them, whatever the case is. There's at least like 20 pamphlets that's related. They'll go back home with that, the patients. All right. So always make sure you mention pamphlets, and actually now they're coming up with these e-pamphlets where they're gonna give them apps that they can download, and then they'll get all the pamphlets and all that. So that will change eventually. But yeah, so just say reading material, leaflets and pamphlets. Always make sure you mention that. Then next thing is follow up. Make sure you always. This is not the follow up that we are talking about. Even if you send them to a specialist, you still have to follow up on that patient, right? That's very
Yeah.
important because you don't know what's going to happen. You don't know if the patient is actually gone and seen the specialist, because that once they leave your consultation room, there's no way for you to actively follow up on them, right? Unless they come back to you. So make sure you tell them that I'll also see you again in a couple of weeks, in a few weeks. You can just say, you don't have to be very specific, to see how you're doing. Even if you send them to a specialist, say that I'd like you to go to the specialist. I'll give you a referral, but even if that takes time, I'd like to see you in a few weeks just to see how you're doing. And that's enough. That's good. Just that way that you've sufficiently safety netted the patient. You've sufficiently shown the examiner that you're a safe doctor. All right. So that's management. That's good. Now, your interpersonal skills are really good, but only one thing that I noticed is you are not signposting well. You need to be a little more active about that in your mind. Otherwise, your empathy is really good. But yeah, like I said, signposts, because That way, it does. Even if you're rushing, it doesn't seem rushed, because when you're signposting, you end up talking a little slow, because that is something that you have to keep in mind. So you can signpost as much as you want. You can signpost for every question also if you want, because that will make it more natural. The entire conversation seems like you're being very empathetic and nice about everything that you ask. But yeah, other than that, don't worry. It's really good. Uh, so one main advice that I'd like to give you is practice with the timer. Like, keep looking at the timer as you practice. Don't, it's not just the points that you need to cover, it's the time you need to maintain. All right.
All right,
Anything?
good luck, Dr. Tanmay. And I just wanted to add one more thing. Depression cases are very common, commonly tested in PLAB. So do understand what all resources, as soon as you identify depression, make sure you safety net, give a crisis plan. So we've made some comprehensive videos about this in our module. We'll be posting that in the group. You can just take a look at these, videos and understand what all, management that NHS offers. Because definitely these are cases that are highly sensitive. So you need to be such. You need to be very sensitive when it comes to depression. All right. Thank you, Dr. Tanmay.
One question.
Absolutely. Go ahead.
Were my facial expressions okay, or do I need to change them as well?
No, don't worry. They're not gonna penalize you for your facial expressions. Don't worry about that. Yeah, that's okay.
I
Thank
will
you
have a
so
natural
much.
conversation. I'm sorry, you
The
mentioned?
feedback was really detailed and really good. Thank you so much.
No problem. Absolutely. We'll also try our best to help everybody in the same process. So, usually when you're thinking about the consultant, think of them like, a fly on the wall. Like, so it's like any other consultation. If it's your first day in NHS, there'll be a lot of eyes on you, but you need to do what you need to do, right? You'll be acknowledging a senior if he's in the room, but you still need to check out your patient. Right. So it's something like that. So that's how you did it, in as soon as you enter, you're like, may I proceed? Or hello, good evening, examiner, or good morning, examiner. Just acknowledge the person, because even in a real setting, if there is a senior over there, you will be acknowledging them, and you will be conducting your entire, consultation as it is. And there will be people who will be monitoring you, even in your first day of NHS. That's basically how you need to take the examiner as, right?
Okay.
You need to conduct your consultation, you need to do what is right, but you need to also understand that you're being observed. Yeah.
Yeah.
All
Thank you
right.
so much, guys.
Definitely. Thank you so much for joining us. And we'll be posting those. We'll be just posting those videos again, so you can take a look of all the resources that you can use for depression.
Yeah. Thank you so much.
Thank you, and thank you, Dr. Umar, as well. Do you have anything else to add, Dr. Umar?
No, no, it was perfect.
All
All
right.
right. Thank you,
It's
guys.
a really nice simulator as well.
Thank you for choosing Turing Med School. Good luck with your preparation.